a very big organizing committee, and especially Ms. who has been with me on this platform here and now. It is important also to already a success as it is knowledge across so many different domains of pediatric care, truly an interdisciplinary conference. Thus, with that said, so I want to make this in a small but meaningful way to effective pediatric care. Now, I also take the distinction of being probably the only person who's speaking on the dental aspect of pediatric care, if I'm not wrong. As I went through the schedule, I was the only one who's speaking on pediatric dentistry per se. So today, since all of these sessions have been very engaging, I am really going to put this disclaimer out that I'm going to bore you with a lot of numbers. So today's session is more of an attempt to generate awareness of the dental situation and the role of all pediatric healthcare providers in engaging meaningful ways to work towards the dental healthcare in children. So when I define pediatric dentistry, it itself is defined as a primary and comprehensive age-defined specialty, which does provide preventive and therapeutic healthcare for children and infants and children through adolescence, including those with special healthcare needs. Now, having said that, when I cover this definition, it's really comprehensive in a way that I take the distinction of being the only person in the aspect of dental care who looks at not just 20, but an overall 52 teeth. So yes, we pediatric dentists take the onus of treating not just 20 milk teeth, but 52 overall teeth in the lifespan of a human being. This is because I did cover that we also are engaging in individuals who are anxious as well as who require treatment in the domain of special healthcare needs. So yes, let me take that responsibility and really that onus of treating 52 teeth as opposed to just 20 teeth as we are often considered of treating. And when I talk about this aspect of being a clinician or a contemporanean, it is really important to consider that dentistry has been taught and practiced for decades or centuries. But at every point in time, we can understand that the time frame with which the understanding of the disease etiopathogenesis, the understanding of different treatment options has widened over time, and the time duration that it takes for the change of this concept of understanding the disease as well as understanding the treatment options, including even risk categorization of different subjects and optimally strategizing certain treatment plan with challenges of compliance is very important to be considered. Now, often when we discuss dentistry, we, as I told you again, that we talk about numbers, but it is also important to consider the qualitative aspects of dental care, especially the patient's perspective. Now, in my experience, it is always been an understanding with numbers that what is the prevalence of dental disease. And today, as I have already outlined that I'll be speaking on dental caries more than any other problem, it is important to consider this in a qualitative aspect as well. And when I do consider treating patients and when the patient sits in front of me during the consultation visit, that is the initial visit, it is important to outline that the patient understands and takes responsibility for whatever has gone wrong with the child, whether knowingly or unknowingly. Now, once the patient has accepted that there is a problem, certain questions do prop up in that initial conversation. The questions like, why are they decayed? Don't you eat? My child does not really eat chocolates. What to eat to prevent dental decay? How to prevent these problems? How to treat these problems, essentially. So such are the questions that are normally asked. And the hallmark of treatment in prevention of dental decay has been fluoride. So when this conversation comes up in a casual way, these are the sort of questions that are normally asked to a pediatric dentist. So now for me to approach this problem, there are different perspectives that I consider. Now, it would be foolish to consider that I'll be speaking only from the dental point of view and the dentist point of view in relation to the patient. But I consider that the most neglected part is the role of a pediatrician or a pediatric healthcare provider other than just a pediatric dentist. From the parent perspective, when a dental decay is assumed or is shown to the parent, the response primarily is it's a primary or a milk tooth. It will fall off eventually. So this is an attribute of gross neglect, or possibly the patient is uninformed on the various aspects of dental decay, their prevention and treatment. Now, when I come to the pediatrician's perspective, which in this context becomes very, very important, is The pediatrician would say rather, I can see a problem. So you need to brush well and see a dentist. So this is key. This is an important factor for me, wherein there is acceptance of a problem and there is some target towards achieving a therapeutic outcome, as well as the referral to a dentist. Now, this is really only academic, that a pediatric dentist perspective would be, yes, there is a problem which can be treated and further such problems can be avoided. So here the attributes could be acceptance, therapeutic approach to treatment of dental decay, prevention of dental decay, and risk determination. So when we sit across and all of the healthcare providers, especially in the pediatric setup, once or maybe multiple times, these questions have been put forth to us, such as why to brush with a toothpaste, why to use a mouthwash, why to floss, which toothpaste, which mouthwash, and which floss to use, and how to floss. Do we need to visit a dentist? How frequently we need to visit a dentist? And will dental decay have an impact on the overall health of my child? Now, it is really important for the pediatrician to understand that the role of a pediatrician in referring the dental problems to a pediatric dentist or dentist is very, very important. This is partly because of the fact that whenever a child reports to a pediatrician, the frequency of reporting of that child to a pediatrician is quite high as compared to a pediatric dentist. All of the guidelines that give us an instruction of following up a pediatric dental patient at least at 6 monthly follow-ups does keep us in the outlier zone of following them up much more frequently. So when we are considering children from neonatology up to the age of say 13 or 14 years, in which case in my country that's the zone in which we treat pediatric dental patients, it is important for the pediatrician because on an average, when I talk to experts in this field, the frequency of visiting by a patient or a parent to a pediatrician is at least once in 2 months. Now compare that with the frequency of visiting a dentist at least thrice. So that means one visit in 6 months as opposed to one visit in at least 2 months. So the role of pediatrician in identifying that initial problem is paramount. Whenever the child smiles at you, whenever the child wishes or greets you in your operatory, you could easily identify problems in at least the upper anterior teeth, which could be sufficient as these are the most prominent areas where dental decay manifests itself in the early part of this problem. So a prompt referral at that point in time is paramount to preventing this problem. I will continue the problems associated with dealing once the problems have occurred as opposed to preventing them, and hence the role of pediatric healthcare provider, let alone a pediatric dentist, of course, that is paramount for us, but for other healthcare providers also is equally engaging and important. So this is how the understanding of dental treatment is in most ways, that this is how people perceive the dental treatment to be. So from the joke apart, let me now discuss exclusively with the help of evidence. And when I talk about evidence, an evidence-based approach to practicing dentistry, I want to talk about systematic reviews. I want to talk about high-quality meta-analysis. I want to talk about Cochrane research in relation to dental treatment. So this presentation from now on becomes more of informative, a review-based process rather than anything else going into the specifics of dental problems and their treatment. So the first article here says that the dental caries prevalence is 46.2% in case of primary teeth and 53.8% in case of permanent teeth. So that is almost half the population globally has been afflicted by this disease. Then we come to something called as early childhood caries. Now this early childhood caries is a phenomenon that occurs below 6 years of age. To be precise, it is termed within the age group of 71 months, which is just short of 6 years. So now when you look at age-based incidence, you can see at the age of 1, the prevalence is 17%. At the age of 2, it is 36%. At the age of 3, it is 43%. At 4, 55%. And at 5, 63%. So that is the kind of burden that we are dealing with if it remains undiagnosed or untreated over a period of the first 5 years of life. Then we come to similar incidences in case of other dental problems such as traumatic injuries, in which the incidence as reported is only 15.2% in case of primary teeth and 22.7% in case of permanent teeth. And when we consider malocclusion, so there are tremendous number of factors that are involved in considering this, which is 39 and 93%. Now, again, the significance of this kind of prevalence with malocclusion again translates to its treatment needs in case of dental caries, because malocclusion is one of the most important factors that can also lead to dental decay. Now, coming to predisposing factors, as has been spoken throughout the length and breadth of these 2 days of the conference, breastfeeding forms an integral part of pediatric care. and it has been recommended that exclusive breastfeeding for a period of 6 months is always going to be healthy. But from the dental context, we have to consider beyond the age of 6 months, because that is the time where I'm considering the first primary tooth to erupt in the oral cavity. The disease process will not show itself unless the first primary tooth has been established by eruption into the oral cavity. So as this literature says, the children which are breastfed for greater than 12 months had an increased risk of caries as compared to children breastfed at or lesser than 12 months, with the odds being twice as common. So in children who are breastfed for more than 12 months, the risk of dental caries is twice as compared to children who are breastfed at 12 months or up to a period of 12 months. Then we come to bottle feeding and dental caries. It is obviously detrimental in multiple regards. So breastfed children were less affected by dental caries than bottle fed children. That is almost half the chances of developing dental decay in such children. Then we come to prevention of ECC. Certain preventive programs for pregnant women, advice on on diet and feeding, prenatal oral health care, integration of the maternal and children's oral health promotion in nursing practice, maternal oral health programs undertaken by non-dental health professionals, dental health education in combination with use of fluoride for children, early preventive dental visits, and the use of fluoride varnish and toothpaste with more than 1000 ppm of fluoride. So this is what I'm trying to consider in context of this conference, that the role of all of these healthcare professionals, not just the dentist, is very, very important in decreasing the problem of dental decay. Then we have obesity and dental caries. So children with overweight and obesity have a higher dental caries experience when compared to children with normal weight. Then another correlation between ECC, that is early childhood caries, and weight. So overweight children are obviously at a higher risk than underweight children. Normal children at a higher risk than underweight children, and overweight children again are at higher risk than normal children. So it is essentially now, with this kind of evidence, a disease of plenty. Then we see dark spots on the surface of teeth, which are essentially stains due to use of multivitamins. So it was suggested that photogenic bacteria stain 67% protective against dental decay. So this is an overview of predisposing to dental. Now, of course, the questions that I just those slides back, preventive therapies at home, how can they influence the outcome in dental decay? So these are, most of the reviews that I'm talking about are Cochrane reviews. So they represent the top order of evidence for any kind of healthcare intervention. So here it is suggested that in case of permanent dentition, till the time the permanent dentition starts coming into the oral cavity, a toothpaste ranging between 1450 to 1500 ppm of fluoride, that is parts per million of fluoride, is found to effective effect. Xylitol, a sugar substitute, along with fluoride, can decrease dental caries by 13% over a period of 3 years. When we talk about fluorosis risk, obviously it is also to consider the fact that fluoride in excess amount can also lead to fluorosis, which again is detrimental to oral and dental health. So fluorosis risk in children younger than 6 years of age is very negligible when you use fluoride toothpaste at or lesser than 1000 ppm. So another base of evidence is the use of mouthwashes or mouth rinse. Now, it is being a constant theme that you associate the use of fluoride and preventive dental regimens. So here, fluoride mouth rinse can lead to substantial decrease, that is 27% reduction in decayed, missing, or filled tooth surface, and 23% reduction in case of decayed, missing, or filled teeth, that is T component. Then additionally, supplements in the form of fluoride supplements such as tablets, lozenges can lead to 24% decrease in DMFS, that is decayed, missing, and filled tooth surfaces in case of the permanent dentition. And fluoridated milk. Now, this is the review which has been modified again in 2015, which suggests that use of fluoridated milk itself can lead to 13% decrease in DMFT index. So fluoride gels, if they are supposed to be used at home, then they cause 28% reduction in DMFS in case of permanent teeth and 20% reduction in case of primary teeth. Use of pit and fissure sealants in professional care, again, wide range of preventive outcome, that is 11 to 51% decrease in caries in permanent dentition. In case of chlorhexidine varnish, now this has been a common material that has been again used in dental practice, but evidence suggests that is really not significant in preventing dental caries to a significant extent when you compare it with a fluoride based varnish. then sealant and varnish application. So professionally, if you applied fluoride varnish as well as do a pit and fissure sealant, the combination is better, but again, the level of evidence is low. And professional flossing, there are not many articles on home flossing in case of children that are younger than 6 years of age, but professional flossing, that is flossing in a dental clinic, will give you 40% protection against caries risk reduction in case of primary teeth. Now, combined home and professional care. So now the increment, that is the increment in additive benefit, as you can see, when you use fluoride gel and mouth rinse as against mouth rinse alone, there's protective effect by additional 2%. When you combine fluoride gels and mouth rinse against only gel, the protective increment increases plus 23%. When you use fluoride mouth rinse and toothpaste versus only mouth rinse, the additive effect is plus 5%. And fluoride toothpaste and gel versus only gel, the additive effect is plus 10%. So when we talk about the effects of the detrimental effects of this disease on the effect of on the overall effect in a child, we can look at dental caries and stunting or wasting. So there has been association that has been established between dental caries prevalence and the severity with wasting and shunting. When we talk about early childhood caries and oral health related quality of life, there is definitely a negative impact. As you see, in case of children with early childhood caries, the effect is twice. So there is twice detrimental effect or negative impact on oral health related quality of life. In case of children with severe early childhood caries, which is classified as the caries risk or the occurrence of caries in children younger than 3 years of age, it is 5 times as detrimental or as a negative impact on oral health related quality of life. Now we come to the treatment aspect of dental caries. So there are certain treatment aspects which work so far that we discussed, work in the protective or preventive domain, but there are certain aspects that can be treated. These processes set in restorative as severe. Then we can talk about sodium fluoride varnish and 2% APF or acid-related phosphate fluoride gel over a period of 12 months or more. And we can talk about minimal intervention approaches in which we don't go to the full extent of removing the dental decay, but conservatively treating or biologically approaching the treatment of dental caries, which could have just 38% of application of an agent such as silver diamine fluoride could give 81% protection against the advancement of disease or occurrence of that disease. So let me talk a little bit about the side effects of doing treatment in case of dental caries when the disease process has already established itself. So this is a very, very well-known fiction trial, which is it's based, of course, in the UK, in which 3 treatment approaches through the NHS were considered, wherein conventional treatment, biological treatment, and preventive treatment. These were the 3 treatment regimes that were opted in a multitude of centers across UK, and it was found out to almost anyone's surprise that there is no significant difference in treatment approaches either involving preventive therapy or biological treatment options or conventional build technique kind of treatment options. So there's no difference in whether you don't treat caries or you treat caries in the outcomes. So it essentially highlights, what the study highlights is that primary prevention of the disease is paramount, and it emphasizes the importance of early prevention for young children to avoid dental caries altogether, rather than trying to manage multiple dental carious lesions. It's a very well-known trial with a lot of repercussions across the dental fraternity and has laid out some guidelines for us as pediatric dental practitioners to consider. So now when we consider conservative treatment options and not the full-fledged or conventional treatment options, using topical agents or modifying the surface which is afflicted by dental caries could have better outcomes as compared to treating caries completely, that is removing the entire carious lesion and restoring it. So alternatively, use of 38% silver diamine fluoride, which I already told you, Hall technique crown, which is again an established which again has taken the dental fraternity by surprise, selective removal of carious tissue, and atraumatic restorative treatment for single surface cavities are much effective as compared to no treatment or conventional treatment using restorations. So these have to be an increase in has to be considered on these techniques, these conservative or biological, so-called biological treatment options, managing primary teeth rather than as a compromise option wherein conventional treatment may not be possible because of behavioral issues or compliance-based issues. Again, when I consider radical treatment options in the form of pulpotomy or pulpectomy or lesion sterilization and tissue repair, these, let me just not go into the details of these treatment options, but these are much more radical, wherein the complete diseased tissue is removed, the pulp tissue is removed to a significant extent, and the success of that has been put up here: 80%, 93%, and 76%. But one important factor that has to be considered here is the maximum duration of success has been evaluated only till 24 months in the research that has been posted so far. Now, this is significantly because of two factors. That is, one factor is obviously the consideration for recall. As we know, in a randomized control trial, follow-up plays a very, very important role. And when the patients do not report after a certain period for follow-up, the outline of treatment has to be curtailed, or the treatment outcomes have to be curtailed or cut down in such a way that the treatment outcome cannot be evidence-based, and recommendations or guidelines cannot be formed. So one consideration is because of recall, and second is because of survival analysis. Now, I am going into the statistical jargon, but when we consider survival analysis, the survival analysis drastically drops down beyond the age of 24 months. So an important question has been put up in front of dental fraternity, that when we consider radical treatment approaches in the form of these three treatment options, are we really treating them only with an estimated success of such numbers up to a time frame of only 24 months? That is, any treatment that any radical treatment option that we consider is only for a period of 24 months. It's an important question that has to be answered. Of course, evidence has to be taken with a pinch of salt, because as we commonly say in epidemiology or statistics, that there is lies, black lies, and then there is statistics. So considering all of that as well, factors that contribute directly to the outcomes of success or failure in these options. So how do we decide which is the best treatment option for any child with dental decay or at a potential of dental decay? It importantly has to be evidence-based. Now, with evidence-based treatment approaches occupying a center stage in any platform, in any sort of disease situation, an evidence-based approach is very, very important. But at the same time, the caregiver's experience can lay clues or point you in the direction of something which is evidence-based but not does not contribute significantly in means and ways to the potential level of evidence. Because as we know that there are certain publication biases that crop in, that positive reporting of outcomes has been frequently done and negative reporting has been hidden, of course. And when we talk, like, I mean, past few sessions that I heard today have been on Ayurvedic approaches. Of course, Ayurvedic approaches are very, very difficult to get published, and systematic reviews in those formats are very difficult to get, let alone meta-analysis and umbrella reviews. So a caregiver's experience can also contribute in a meaningful way to giving the best treatment for the patient. And most importantly, what we do not consider is the approach of the parents or parental or patient's acceptance. So you saw in the previous slides, I did discuss about 38% silver diamine fluoride, one of the most standout treatment options for initial caries or caries up to the level of dentin. Now, the biggest disadvantage of this treatment option is the moment you apply this solution to the carious tissue, the tooth almost instantly turns black. So an aesthetic outcome which is not very, very preferentially acceptable to the parents has to have a say in the treatment planning in such situations. So for me to give a best treatment option for my patient will vary at every stage, at the acceptance level of every patient, which will be evidence-based, which will take my experience into perspective and the acceptance level of the patient or the parent. So just in a nutshell, for me to give you an idea for effective and optimal protection against dental caries, you must consider use of fluoridated toothpaste and fluoridated mouthwash at home. A parent must consider supplements such as fluoride supplements and fluoridated milk if it is available in your country. A dentist or a pediatric dentist must consider applying fluoride gel, using pit and fissure sealants, and professional flossing. But I'm missing out on something very, very important, which is a pediatrician or a pediatric healthcare provider must identify and refer as early as possible to prevent these complications, to prevent the inconsistencies in reporting of treatment options or treatment outcomes, which have been abysmally very low in case of radical treatment options. So my take home message would be: dental caries is an exceedingly heavy burden on the population and society, which just keeps getting. Best strategies still include prevention and early management. with the growing pace of increase in global prevalence of dental caries, no number of dentists or pediatric dentists or policies will be adequate to solve this ever multiplying pandemic. Cooperation, understanding, and engagement of all pediatric healthcare professionals or providers will play a pivotal role in tackling this problem. So these are my references. An important note, when you look at the references, all of these references are high quality RCTs, most of them being systematic reviews, and the ones that I have highlighted or made them bold are all Cochrane reviews in this regard. So at least 12 to 15 Cochrane reviews are what I have considered in making this presentation. And an approach only with a dentist or a pediatric dentist will not suffice for me for reaching from the left to the right. I need the support, or the dental fraternity or a pediatric dental fraternity will of course need a multidisciplinary approach, a multidisciplinary awakening of all specialties to tackle this kind of problem. Thank you very much for your patient listening. And again, a big thank you to the organizers of this event in giving me an opportunity to work and impart in whatever little meaningful way to contribute to this platform. Thank you so much.